Good afternoon, and welcome to this seminar in the series of the Department of Epidemiology of the Harvard School of Public Health. My name is Bert Hoffman. I'm the chair of epidemiology, and it is my distinct pleasure to have here Dr. Rulla Tamimi. Again, may I say, Rulla did her Doctor of Science with us and left 2020 to New York, and she is now the chief of in the division of epidemiology in the Department of Population Health Sciences and the associate director of population science at the Sandra Edward Mayer Cancer Center. This is all at Cornell, the Weill Cornell Medical College in New York. Dr. Tamimi is a great, very renowned breast cancer epidemiologist and an epidemiologist at large. Over 400 publications in various aspects of breast cancer, genetic, molecular, lifestyle. And it's wonderful, as I already said, Rulla, to have you again here with us. And we look forward to your seminar, Research Addressing Cancer Disparities in New York City. Dr. Rulla Tamimi.
Thank you so much, Bert. It is wonderful to be here. And let me just make sure everything looks right. Please tell me if that looks like you can see it.
It does.
Okay,
Yeah. Yeah. Thank you.
wonderful. Well, really exciting to be here today. Thank you so much for the invitation, Bert. I feel like my seminar today is a little bit different than what I normally talk about. I think I've had the, privilege and honor to continue so many collaborations, both at the Chan School and at Brigham and Women's Hospital. But it has been 6 years since I've left, so I wanted to kind of share some of the work that I've been doing here in New York City that is sort of a newish direction for myself. One of the things that I was going to start with is actually just talking about some of my new roles, one of which is the role of Associate Director for Population Sciences at our Cancer Center. As Bert mentioned, I was invited to talk to our PhD students about what this role means. And so I realized that I think, especially for students, they may not know what that role means. So I was going to start out with a little bit of introduction in terms of what an AD for population science at a cancer center might do. I'm going to share a little bit about a recent study that we just published on breast cancer. I'm going to talk about a U54 center grant that we got, which we are midway through. And then the final thing I'm going to talk about is actually aspirational. It is a grant proposal that I'm actively working on right now. And then we'll end, and hopefully I would love to hear any input, any suggestions, especially for the proposal that is about to go in. So for those of you that may not be part of a cancer center or are not familiar with it, the AD for Population Sciences at a cancer center is really meant to kind of come up with the vision for cancer prevention and control at that center. And that really means overseeing their research program, which is devoted to population science. And that means kind of making sure that there's a really robust research portfolio, that there are grants that are coming in that area, thinking about what could support their members in terms of doing research that is aligned with the mission for the Cancer Center, and really making sure that population sciences and population science initiatives are represented across the Cancer Center, and obviously working very closely with other leaders of the Cancer Center, especially the director and deputy director. And then, oops, sorry, I'm trying to figure out how to move my thing. Let's see, there we go. In terms of our research program, one of the things that I think that is really important for a cancer center is that you're really meant to try and encourage, facilitate, support research that is in line with your catchment area. And so this was kind of a new thing for me to kind of think about what is our catchment area, where is it that we're trying to have impact with respect to our research, and then how do you foster a program to kind of build interactions and encourage faculty to actually do research that is really most relevant for that catchment area. And then really thinking about, if we don't have those faculty, how do we get those faculty? Think about recruitment and think about other resources that actually might help to support researchers to really meet that goal. So when I moved to New York, one of the first things I did was look at a lot of maps to really try and understand New York City. So for those of you who are not familiar with New York City, this is a map of New York City and the five boroughs. Weill Cornell is located on the Upper East Side of Manhattan. Hopefully you can see my little cursor that is hovering over where I'm sitting today. And our catchment area, which is covers most of Manhattan, although not all of Manhattan, is this orange section here. Brooklyn, and then all of Queens. And that represents about 6 million people. And this is our catchment area because about over 70% of the cases that are diagnosed at Weill Cornell, of cancer cases that are diagnosed at Weill Cornell, live within this catchment area. So we serve a very diverse patient population. You can see here kind of the racial and ethnic breakdown. 36% of the population is white, around 21% is Hispanic, 21% is Black or African American, and around 20% are Asian, Native Hawaiian, and other Pacific Islanders. I think some of the really important other population characteristics is that we have a large population of individuals that are born outside of the US. So nearly 40% of our population is born outside of the US. This obviously has important things to consider, especially when you're considering doing research and languages that may need to be considered. So many different things in terms of developing interventions and research studies in these populations. And so one of the things I think that is really important when we kind of think about our cancer center is like, what does that mean? Like to do research that is relevant for our catchment area? How does our catchment area compare, say, to the United States? And the bar graph on the left is really our incidence rates that are in the Meyer cancer catchment area. Very similar in terms of like what you might see nationwide in terms of female breast cancer being the number one cause of cancer in our population, followed by prostate cancer. But where we do differ is down here. These are cancers that have a higher incidence rate within our catchment area relative to the United States on average. So we have higher incidence rates of stomach cancer, thyroid cancer, cervical cancer, and multiple myeloma. The other thing, again, our catchment area is huge. So, we have 3 different boroughs that we're covering, but they're very different. Each of those boroughs is very distinct. And so we do see differences when we compare boroughs, say, to Manhattan. So comparing Brooklyn to Manhattan, you can see that we have 63% higher incidence rates of cervical cancer in Brooklyn than we see in Manhattan, higher rates of stomach cancer. A number of cancers are higher in Brooklyn. When we look at our Queens population, again, higher incidence rates of stomach cancer, cervical cancer continue to be 2 of the cancers where there are disparities when we compare geographic regions of our catchment area. And then when we shift to look at mortality, again, you see very similar incidence rates in the catchment area that are relative to the United States. The 2 that do stand out, though, is that we do have higher rates of stomach cancer mortality and uterine cancer mortality in our catchment area relative to the United States. And then for my own research, I actually have I have almost always exclusively done breast cancer research, but after coming here and really seeing that cervical cancer, we have over 100-fold increased mortality in Brooklyn compared to Manhattan for cervical cancer, and 90% higher in Queens relative to Manhattan. And especially for something like cervical cancer, where we now have HPV vaccines, we have pap smears, we have HPV testing. We have so many opportunities for prevention and early detection. It really is troubling to see these higher incidence and mortality rates for cervical cancer. And even for breast cancer, which is where I've done my focus, we do have higher mortality rates, almost 40% higher in Brooklyn than we see in Manhattan. So one of the things in my role of AED is to make sure that people know this, that the people understand and have accessible to them information about our catchment area and are able to do research that is relevant to the catchment area. So one of the things that we have done over the last few years is create a data hub, basically just like a front door, a central location where anyone who's doing population research, and not even population research, even our basic scientists, our clinical researchers, have an opportunity to kind of really understand what is the burden of cancer, specifically the cancers that they may be either treating patients or doing research, and that they can have these sort of inaccessible ways that you don't have to know how to code to be able to really get information on these cancers within our catchment area, and also for people that are interested in doing more research, really have an opportunity to access national data as well. So I'm going to just take a little bit of time to share with you some of the things that we did really to be able to share catchment and patient level data with our cancer center members. So one of the things we did was we created a dashboard, and this is not really that fancy, but it just allowed people, all you have to do is like click and use sliders, and it really gives you information in terms of how many cancers did we see, within a certain time frame. How did they differ by gender, age, race, ethnicity? We have 3 hospital sites. Do we see different in each of the different boroughs? Do we see differences by hospital sites? And just to give people an idea in terms of what the burden of cancer is in our catchment area. And so you can see that in 2023, this is all based off of cancer registry data, which does lag behind. So it is a little bit out of date, but I think in general, it gives you a flavor of kind of high level how many cases we may be seeing each year. One of the other tools that we made available for our cancer center members was Cancer in Focus, which this is a tool that Todd Burris at the University of Kentucky developed, and you're able to apply it to your own cancer center. It really brings in information from geographic information systems. And so what you can see is that you can get a map of your catchment area or your location and really get, as a heat map, some of the different risk factors or census tract information factors that you might be interested in to really understand sociodemographics, some of the health related information. This one here is just looking at BMI across New York City, and you can see there is a huge variability in terms of BMI. This is, again, Manhattan, where, many of the census tracts have obesity levels around 11 or 12%. But if you go to parts of Brooklyn, parts of Queens, you have some of these census tracts where obesity is as high as 40, 45%. So especially for cancer risk factors, I think understanding what these look like across our catchment area is also important for thinking about research questions that we might be interested in, and also the development of interventions to try and address some of these risk factors. Again, because a lot of my work has been focused on breast cancer, I just wanted to give an example of this is looking at individuals who would have met the breast cancer screening recommendations, which are to have gotten a mammogram within the past 2 years. And really just also trying to highlight the fact that we are able, using this tool, you're able to look at both county level as well as census tract level. And I think when we go at the county level, we had sort of also been under the impression that actually breast cancer screening is doing pretty well. The goal for Healthy People 2030 is that 80% of your population would be meeting these recommendations. And so you can see that Manhattan is at 81%. Brooklyn and Queens are both at 78.4%, and Staten Island, which is not part of our catchment area, is a little bit lower. But actually, when you look more closely at census tract, you do see that even though on average, these boroughs are doing well, or these counties are doing pretty well, there are several pockets where actually they are very much lower. So on the Lower East Side here, parts of Brooklyn, parts of Queens, where we do see much lower uptake and meeting of the breast cancer screening guidelines. And again, I think from a cancer center perspective, this is important for thinking about how do we intervene? How do we, especially in these neighborhoods, why are they not being met here? One of the other things that we look at is if we think that the screening is a concern, then we're worried about late stage breast tumors being detected. And so we looked not only at by county, and so you can see that late stage tumors are higher in Brooklyn, although they're not so different. It's maybe 42 to 45 here percent are being detected at late stage. Sorry, not 42, 42 per 100,000. But when we look at by race and ethnicity, you can see this is really driven by racial differences. So non-Hispanic Black women have much higher percentages of late tumors compared to all of the other racial ethnic groups that we're able to look at here. We also looked kind of at the screening specifically now, not at the census tract level, but kind of at neighborhoods within the different counties. And we did identify two particular neighborhoods that really were not meeting the screening guidelines. But there still seems to be a disconnect for us in terms of neighborhoods where we have lower screening rates, but also having this higher mortality rate. And so this suggested to us that maybe it's not just the screening, meeting the minimum screening of getting screened every 2 years, but perhaps an intensity, because many women are getting screened every year, beyond every 2 years. Or could this also mean that there is a difference in terms of the time from initial diagnosis to the time to treatment? And so that actually motivated this research study that we did looking at the impact of race and ethnicity as well as social drivers of health on time to breast cancer surgery. And this was work led by a postdoctoral fellow in my group, Dr. Shadi Azam. And this was just published earlier this year. And we see in our own catchment area as well as nationally that Black women have about a 40% higher breast cancer death rate than white women. For breast cancer, surgery is often the initial treatment modality. And that we know that delays can affect the benefits of some of the adjuvant therapies, including radiotherapy and chemotherapy, and could lead to less favorable outcomes. And prior studies have shown that these longer intervals between diagnosis and surgical treatment are associated with worse long-term survival outcomes. So we wanted to really look within our New York City population to see if there was an association between race and ethnicity, some of the social drivers of health, and delays in breast cancer surgery. And so we utilized Insight. And so Insight is a PCORI-funded clinical research network. It's one of the largest clinical networks in an urban setting in the nation. It includes health systems across New York City. You can see many of them here. And it really pulls together electronic health record information across these institutions. And especially in the US, where we have this fragmented healthcare, this is a unique opportunity not only to be able to look at individuals at one institution, but really you're able to follow their care across these different institutions. So we conducted an analysis using this Insight Clinical Research Network. We identified over 13,000 breast cancer cases between 2007 and 2021. Because we were interested in delays specifically in surgical treatment, and there has been an increase in neoadjuvant treatment, we did exclude individuals that were undergoing neoadjuvant treatment. So that just means treatment prior to surgery. And we looked at our primary exposures, race and ethnicity, as well as neighborhood level social determinants of health, which included household income, unemployment, percent of non-English speakers, and high school completion. And we were interested as our outcome delay in surgery. And we used a definition of 60 days from diagnosis, which there is some literature, there's a large body of literature that has kind of focused on 60 days, and working with our surgical oncologist, that was the definition that we used, although there are alternative definitions that have also been used in the literature. And this is our table one to really kind of provide the landscape of some of the descriptive characteristics of this study population. And we felt like it was important to really look at the two main surgical types that are out there. One that is lumpectomy, which is a localized surgery, and the other that is mastectomy, which is the removal of the entire breast. And you can see the demographics are different for women who are undergoing lumpectomy versus mastectomy. Women who undergo lumpectomy tend to be older, while those undergoing mastectomy tend to be younger. These are the women who we are defining as having a delay in surgical diagnosis. And so you can see the women who had delays under lumpectomy tended to be younger. We also see that women who experience delays for both lumpectomy and mastectomy are more likely to have a comorbid condition and certainly more comorbidities. We also see differences by race and ethnicity in that Hispanic women and non-Hispanic Black women tend to have more delays than non-Hispanic white women. And this just shows to kind of what kind of delays are we talking about and how big are these differences. This just shows you what the median days to surgery are. And so you can see for non-Hispanic white women, the median amount of time was about 20 days, while for non-Hispanic Black women, it was 28 days. For women who are undergoing mastectomy, the time from initial diagnosis to time to surgery, the median time for white women was 30 days, while for non-Hispanic Black women, it was 48 days. And here, this is our multivariate analysis looking at race and ethnicity in relationship to delays in surgical treatment focused on lumpectomy. And for almost every racial ethnic group compared to non-Hispanic white, there was an increase in delay, with the largest magnitude really being for non-Hispanic Black women, who had about a 2.2-fold increased risk of having a delayed surgical treatment relative to non-Hispanic white women. Hispanic women were second worst, around 1.7 times the risk of having delays. When we looked at mastectomy, we saw a very similar pattern. It was a little bit lower with respect to the magnitudes, but the patterns were essentially very similar in that non-Hispanic Black women and Hispanic women were more likely to experience delays in surgical treatment. We also looked at some of the social determinants of health that we had available, especially because, as I shared, about 40% of our population was foreign born, really trying to understand if there's a relationship between non-English speaking. And we see that for individuals that live in areas that are more likely to be non-English speaking, there is an increased risk of having a delay in surgical treatment. Similarly, we looked at unemployment status, and so individuals living in neighborhoods that had higher unemployment rates also experienced delays in surgical treatment. We also looked at household income and percent high school completion as a marker of education. And again, you can see that for individuals that had higher household income and higher high school completion, they had reduced risk of delays in surgical treatment. So some of the strengths of these studies is this really draws on a very large number of women across the New York City area and treated at major health systems, very diverse patient population. Because of our sample sizes, we are able to look to see if there were differences by surgical type. Some of the limitations, I think if anyone has worked with electronic health record data, you know that it can be very messy. And so, we did struggle in that we did not have, we certainly had some missing data, and we may not have had information on clinical factors that we would have liked to have had, including stage and hormone receptor status. The other thing is that our socio demographic factors were really neighborhood level factor based and may not necessarily reflect individual level factors. In this study, almost 15% of women diagnosed with breast cancer experienced what we were calling a surgical delay. We certainly saw disparities with respect to delays that were particularly highest among non-Hispanic Black and Hispanic women. And we also saw that social drivers of health, such as neighborhood level income, education, language isolation, and unemployment, were also predictors of delays of surgical treatment. The study highlights the importance of addressing social determinants of health as contributors to treatment delays, and really, I think, emphasizes the need to identify opportunities for targeted interventions to reduce those disparities. And that sort of leads to this next section that I'm going to talk about, which describes our Center for Social Capital and promoting multi-generational health. So the National Cancer Institute has a persistent poverty initiative, and this was launched, I don't know how many years ago, but at least 5 years ago. And as part of that, this was developed because one of the significant determinants of an adverse cancer outcome are living in an area of persistent poverty. And the USDA defines persistent poverty, or an area of persistent poverty, is living in an area where more than 20% of the population has lived below the federal poverty line for over 30 years. And NCI really wanted to push cancer researchers to think beyond individual level factors. So how can we really come up with interventions that are focused more on either structures or systems, and really looking at the causes of causes by targeting kind of upstream drivers of these health disparities. And so there was an RFA that was released. A number of us applied to these. Our group, we put together a group which included investigators from Weill Cornell, Columbia, and SUNY Downstate to really try and address some of these questions related to persistent poverty and cancer. And we called our center SOCA, Social Capital Promoting Multi-Generational Health. There were 5 centers that were funded across the United States. So we were in New York. There's a center in Utah and Montana. Stanford and UCSF have a center. MD Anderson has a center, and then University UAB in Alabama has a center. And going back to our maps of New York City, you can see when you kind of look to see which of these neighborhoods our census tracts are in persistent poverty. The red here signifies persistent poverty. So New York is really a interesting and just a really interesting area because it really is a city of extremes. You have very, very, very wealthy neighborhoods. And then, as you can see, there are many areas of persistent poverty. So our center really identified 4 priority neighborhoods that really are characterized by being in persistent poverty. So that included Washington Heights, the South Bronx, Western Queens, and Central Brooklyn. And we developed our theme as being social capital. And this really came from some of the work that our community outreach and engagement team has done, doing community roundtables. So going out into communities, having conversations and identifying what was important to them. And so one of the roundtables that our director for community outreach and engagement had conducted was focused in Brooklyn and really asked community members what did they think were the top 3 barriers to early cancer detection and cancer prevention. And the 3 that they identified were financial burden, low health literacy, and the third one was this lack of social support, stigma, and discrimination. And this really kind of resonated with us in terms of thinking about, some of these things we can't really take on, but we felt like social capital, even though it sounds like a very broad concept, is really this idea of factors that, that you can use social connections or social networks to improve certain situations. And so, any one of these metrics here are considered part of social capital. And we really had looked at a model that Gilbert et al. Had published in 2021. And I think Chiro Kawachi is on this paper as well, which is really trying to describe a model talking about Black social capital and social mobility in Black communities. And it really is talking about how systemic racism is really at the sort of the initial root of some of the health disparities that we see. And how can social capital really play a part in trying to be a place where we could actually think about leveraging that for social mobility and impacting improved health. And so we sort of adapted this model for our center, really thinking about we are not going to be able to change poverty, but can we somehow focus on interventions that are focused on social capital that could ameliorate the impact of poverty on health? And our two projects are really focused on education and healthcare. But in addition to our research projects, we also have a career enhancement core, a developmental core, which issues pilot studies, an administrative core, a research methods core, all of which are really trying to build social capital, whether that is thinking about our trainees, developing pilot studies, and really all of this also is influenced by work and input from our community advisor board. The other thing I'll say about SOCA, this was not this is from one of our other leaders was so excited to be able to name the center SOCA because it also has a second meaning besides standing for social capital, but also soca music, which is a genre of Afro-Caribbean music that really has evolved over time and has kind of incorporated other elements from African and East Indian styles. And within New York, especially the major disparities that we see are really worse outcomes, especially for our Black population in New York City. And about 1/3 of New York City's Black population are actually immigrants from the Caribbean. So it seemed very cohesive with what our mission was, and our vision for the center really is sort of in developing infrastructure training that would also grow and kind of evolve over time to incorporate multiple cultures and really try and improve with a positive impact in our community and catchment area. So again, our mission for the center is to reduce cancer health inequities in persistent poverty areas. We developed our projects with community input. We have two large projects, one that's called Cares for You and one that's called Bridge to Quit, and I'll describe those next. We also support junior investigators through several pilot projects and really trying to build a community and a social network for trainees and for researchers who are interested in this kind of research. We also have a really cool workforce development aim, which I'm happy if there's extra time to talk about later. So the first project is this cancer risk education in schools for youth and families, which is Cares for You, which is really the idea behind this is that one way to think about opportunities to reduce cancer risk is by targeting youth and the fact that we think of young people as agents of change, educating them in terms of what are cancer risk behaviors, and the idea that we consider them agents of change. They then go home, they talk to their family members. Can they kind of have that message spread to their parents, their caretakers, their siblings? So as part of this, we are developing a 6-module cancer education program, which is going to be, we're working with Math for America and the New York City Department of Education. We are targeting 4 New York City public schools, training science teachers really to incorporate this as part of their STEM programs. And then in terms of outcome, we're really going to be looking at the students' what they have learned during this. If they have intentions to engage in health promoting behaviors, we're also enrolling their parents and caretakers to see if that influences risk communication that may happen at home. The second project is called Bridge to Quit. And this is really trying to leverage patient portals in federally in FHQCs and FQHCs, federally qualified health centers. And the first aim is actually really just focused on patient navigation. So getting patients to sign up for those patient portals. There has been low uptake in the FQHCs for these patient portals, and this is to help them to get onto those patient portals. And then the second aim is focused more on getting people to the New York State Smokers Quit line, should they qualify. And then the aim 3 is looking at different kinds of referral to the quit line. And I think the one of the really nice things about this study is that the aim 1, I think, has the opportunity to be expanded towards beyond quitting smoking, but for other health interventions. I think once you're able to navigate people towards the patient portals, I think there's a lot of opportunity to implement other interventions as well. We also have been fortunate enough to fund a number of pilot awardees. And you can see here a range of studies that people have been able to look at. I realize that I am running out of time, so I'm going to go very quickly through FIERCE, which is my aspirational study. We submitted a letter of intent to PCORI and were invited to put in a full application. And so this is called FIERCE, Fatigue Intervention Exercise for Recovering Cancer Survivors Endurance. So fatigue is cancer-related fatigue impacts up to 90% of patients who are undergoing active treatments. Fatigue is one of the things that they complain about most, but also it limits daily functioning, can affect mood, independence, and impact treatment tolerance. Exercise is actually, even though it seems counterintuitive, exercise has been shown to reduce cancer-related fatigue and has a number of other positive benefits listed here. The American College of Sports Medicine and the American Cancer Society both recommend endorsing exercise actually as a first-line treatment for cancer-related fatigue. But despite this, there is not a lot of uptake. And there seems to be decisional conflict both on the part of the provider to recommend, especially during active treatment, as well as patients, whether during active treatment is really a time that they should be undergoing exercise. So we are proposing a community-delivered exercise oncology program, which would, we're looking at fatigue again at 12 weeks as our outcome using a FACIT-F scale. The secondary aims would also, beyond looking at fatigue, we're interested in looking at quality of life and mental health outcomes, as well as treatment adherence. We've partnered with the YMCA of Greater New York as part of YMCA's, not all, but some YMCAs have Live Strong at the YMCA program, which is a 12-week program focused on aerobic and strength training specifically for individuals undergoing cancer treatment. Again, we're leveraging Insight. And again, here's another map of New York City, but just to show that we are really trying to identify YMCAs in areas where we have high volumes of breast cancer patients from Insight. And in this way, we would be able to enroll using the Insight platforms and be able to link to their electronic health records to be able to look at treatment adherence as well as other important variables. This will be a randomized control trial. We'll also randomize either to Live Strong at the YMCA or Enhanced Usual Care. Enhanced Usual Care is going to be these flyers, which we have developed. A number of us on the research team have joined the New York State Cancer Consortium to develop materials related to physical activity for cancer survivors. And we have partnered with a number of stakeholders for this project, including Susan G. Komen, the American Cancer Society Cancer Action Network, as well as our New York State Health Department. And if we're successful, we really hope that this would kind of move the needle to be able to make exercise oncology something that you could prescribe for, get reimbursed for, and really be able to improve the lives of individuals who are living with cancer. So just to conclude, social drivers of health such as poverty and education really do impact morbidity and mortality in New York City. We observe disparities with respect to breast cancer mortality, especially with respect to race and ethnicity, as well as other structural neighborhood factors. Developing these interventions to overcome these factors is really the direction that we need to go, but it is time, money, resource intensive, but is really, I think, what is needed in order to impact changes in these areas. And with that, I will acknowledge many colleagues here at Weill Cornell, Columbia, SUNY Downstate, and most recently, my partner at the YMCA of Greater New York, Marjorie Jean-Jacques, for our proposed study. So I thank you for your time, and I hope I didn't go over too much.
Thank you, Rulla, very, very much for this great overview on various studies, SOCA and fears, and in a more general sense, disparities in cancer in New York City. Wonderful to have you, as I said before, and perhaps we have questions or comments from the audience. For example, I see Lorelei Mucci. Lorelei, I don't want to put you on the spot, but I think you may want to say something.
Well, yeah. Well, first of all, it was an amazing talk. I'm sorry, I'm like waiting for the train, but I think also what's really fantastic, and Bert, I mean, you've thought about this a lot, is the importance of descriptive epidemiology in understanding not only the burden of cancer, but thinking about ways to design epidemiologic and clinical studies to address it. So I think, first of all, just I applaud you for the work that you're doing in the Cancer Center, but just also just thinking about these issues from the beginning all the way through. I'm wondering, actually, I wonder if you could talk a little bit about some of the work that's going on in some of the other cancers where you highlighted like that there are this excess burden within your catchment area, whether it's epidemiologic studies or others. So maybe you could talk a little bit about some of that work if you can.
I mean, I think this is such an important question, and we struggle as leaders because, like, as you saw, especially like something like stomach cancer or cervical cancer, I do think we are really gearing up to do more work, more in cervical cancer. It ends up being, I'll be honest, we don't have a ton of faculty researchers doing work in stomach cancer. So this then becomes an area where we have to say, we want this to be a priority. We need to recruit somebody who is going to do this, to lead the charge or build a research program in those areas. So I think as a cancer center, we have struggled because everyone's got the big three. We still have to focus on prostate cancer, breast cancer, lung cancer. But we also seem to be in a very unique position where something like stomach cancer, and again, cervical cancer, it's just like very, especially today, no one should be dying of cervical cancer. It needs to be a higher priority.
Right, and kind of just a follow-up, do you think for the stomach cancer, do you think the excess rates are due in part to some of the migrant populations that you have in your catchment area, or what do you think might be some of the underlying reasons for that?
I do think so. I do think, we do have 40% of our overall is foreign born, and especially in, Queens, I think we have a lot of immigrants that are coming from Asian countries where we know that stomach cancer are at higher rates. So I do think that is certainly influencing it. I don't know if but honestly, I think more research is really needed, and I don't think we've quite tackled that yet.
Thank you very much. Any further questions or comments? put it on the chat or raise your hand. Can I ask you a question, Rulla? We have limited time only, but you basically said there is in really great disparities in breast cancer screening programs, although the overall yield of 80% is not that bad, I thought. I thought it was impressive in a way. But there are disparities clearly. There is, particularly in late stage breast cancer, there is a difference, and then the delay until surgery, whether lumpectomy or mastectomy. And then you said we need targeted interventions. And so you then elaborated on the big topics. This is financial poverty, it is literacy, and it is discrimination. And I thought, ooh, if you want to do something about that, that's a really long-term plan, has to be. Yeah? And so I understand now that you focus particularly on education and in schools. Does that mean that you, in some senses, leave behind a group of people that is not reached by the schools, or how do you see that, if I may say?
Yeah, I think that, that is one project which, again, like I really applaud Erica Phillips, who is leading that, because the idea of starting and, really changing the way that we educate students and middle school students, some may even say that's either too late, like we need to be starting earlier. So I think that is one place to be thinking about it. The study that we're proposing to do, I think, is really trying to think about outside of the healthcare system, using community-based organizations as other places where people might be getting care. And I do think the YMCA, whether it's the YMCA or either community centers, they have done a lot for, say, like diabetes prevention, for weight management that is outside of our healthcare systems. So, I do think, especially in areas where you might have more poverty, you might have underinsured individuals. I think thinking outside the box to kind of come up with some interventions is going to be really important, especially for some of these risk factors.
Thank you. Thank you very, very much. I appreciate very much what you've said. I thank you very much, but I would like to say two more things. One is for next week. That's just we have same time, same place, another seminar, and that in that case it is jointly with Maternal and Child Health, the unit in Harvard Chan, and it is Dr. Bill Copeland who will talk about pediatric childhood mental health and the changes over time. Very, very interesting topic, of course, from a point of view of, amongst others, the pandemic and long COVID. That was my first point. My second point is, Rulla, it's great to hear you again. I heard you before, of course, but it's great to hear you and see that you are doing very well. And I thank you very, very much for this great seminar.
Thank you so much. It's been wonderful. So thank you.